Hi, thank you for listening to my presentation. This presentation is going to be looking at flow cytometry, specifically looking at how we can reduce costs, increase efficiency, as well as implement some new emerging technologies to improve patient care. With that being said, just a brief overview of the executive summary of this. Obviously, the flow cytometry department is an important partner with the JTCC Cancer Center at Hackensack University Medical Center, as it insists on helping diagnose and immunophenotype different types of cancers or suspected cancers in patients. Switching to that new emerging LPDST screening tube will actually be able to reduce the turnaround time as it requires less screening tubes to be used for each leukemia and lymphoma diagnosis. It will be able to recapture FTEs based off of labor productivity due to the decrease in the amount of work that would have to be done for each diagnosis, and would actually save the department over $50,000 in the year one, as it will once again require fewer screening tubes for preparation. As I said before, the decrease in the turnaround time will result in quicker treatment for patients, as be able to diagnose a cancer patient quicker, as any oncologist will tell you that's a very important step into treating cancer. And the most important thing to look at when we're looking at this is that there's no actual additional machinery required for this implementation, and that the validation for this can actually take place within the flow cytometry department on the cytometers that they already have. So the objective for this research that I did was unique to lymphoma and leukemia immunophenotyping. It wanted to be minimal impact on operations and also increase physician experience. As I mentioned before in our presentation, we wanted to decrease costs, increase efficiency, and increase patient care. A brief overview of flow cytometry at its heart. Flow cytometry uses a fluidic system, an optic system, a detection system, and then analyzes that. With that being said, the screening tube, it uses conjugated antibodies within it that allow detection of different light characteristics once a laser hits a cell going through the flow cytometer. The data analysis is fundamental upon the principle of gating. The gates and regions around the populations of cells and characteristics are different scatters, forward scatters, or ambient scatters. And all of this allows a flow cytometry technician to use that analysis to help diagnose what specific type of cancer a patient might have or what specific traits the cells within that cancer show. Our current state uses a 10 color, 10 antigen screening tube. We had about 3,200 diagnostic lymphoma tests that we performed. Those tests require two screening tubes to look at the T and B cells. And we also looked at leukemia, which had close to 1,700 diagnostic tests performed. They used 5 screening tubes per diagnostic, looking at blasts, monocytes, granulocytes, hemostasis, and plasma cells. So if we look at our current state, what we're looking at here is a different fluorochrome, such as FITC, PE, ECD, as well as the screening tubes on the left. You'll see the T cell, B cell. Those are for our lymphoma testing, and then the remainder are for our leukemia testing. And the titer is the amount of microliters of the conjugated antibodies, such as CD4, CD33, et cetera, that we use. All the way on the right-hand side, you'll see the estimated cost per tube. And as I mentioned before, it's important to remember that when performing these, we were doing 2 screening tubes for lymphoma testing, as well as 5 screening tubes for leukemia testing. So those costs do add up. When we look at that, our current state cost analysis, we're looking at approximately $170,000 for our screening tube costs on lymphoma patients. And we're looking, lymphoma screening tubes. And we're looking at approximately $117,000 cost for the screening tubes that we utilize in leukemia diagnostics. For the sum total, we're looking at close to $286,000 just on cost for the screening tubes alone. So as we mentioned, we wanted to kind of look at a new emerging technology, and we found research that a lab up in Canada was doing a 10 color 15 antigen screening tube. So we're increasing the amount of conjugated antibodies by 5. This new screening tube reduces the retest rate to, it's actually 25%. I'm sorry, I don't know why it says 0. So it's decreasing the amount of screening tubes we need to use by about 75%. When we look at the lymphoma, again, these are the same diagnostic. We use the same numbers. But as opposed to running 2 screening tubes per diagnostic with lymphoma, we're now running 1. And as opposed to running 5 screening tube diagnostics for leukemia, we're running 1. So it really decreases the amount of screening tubes that we're using by close to 10,000. So the future state screening tube looks like this. And as you can see, again, on the left-hand side, we'll see what different types of conjugated antibodies that we're going to be using, as well as the clones specific to them. We'll look at the wholesale price, and what we did was implemented a 47% discount on bulk sale prices, which is consistent to what we have now. And on the right-hand side, you'll see a specific cost per test for each conjugated antibody, resulting in the bottom right of $47.80 per test, which is a little bit more than twice what we're paying now. But it is important to remember that instead of using 5 screening tubes for our leukemia diagnostics and 2 screening tubes for our lymphoma diagnostics, we're now only using 1 for each. So when we look at the cost analysis for the future state, we're seeing that we're actually going to be under what the current state cost analysis was. The future state is $152,000, and the future state for the leukemia diagnostics is about $80,000, which is a significant reduction because we're doing, I want to say close to 6,000, 5,000 tests less than we were doing. I'm sorry, we're utilizing that many screening tube less. So the sum total comes to about $233,000. Again, that's $53,000 less than our current state. And when we look at our benefits, we'll see that that is what the potential cost savings in just reagents is to implementing this screening tube. The more important thing that we're looking at now is we have a quicker turnaround time for patient diagnosis. Instead of utilizing 2 screening tubes or running them at the same time on 2 different cytometers, we only need to use 1. And we'll actually be able to use the FTEs we have allocated for this in other areas of flow cytometry, which will actually increase the internal efficiency of the department. And more importantly than the cost savings is actually the physician satisfaction that we'll be able to achieve due to this decreased turnaround time. As we mentioned before, any oncologist is going to welcome a quicker and more accurate diagnosis as opposed to a more timely one. So implementing this new LPDST screening tube will be able to achieve that. There are a few barriers that we're looking at, but none actually pose a major threat to implementing this technology. Validation of the course is one. The validation looks at correlation studies as well as an analysis of the outcomes of the new screening tube versus the old screening tube and specificity testing as well. We want to make sure that what we're using is consistent with the type of diagnosis that we were putting out with our old technology, but we want to make sure at the same time we're able to achieve that increased efficiency. And then there may be some physician pushback with this. Physicians are comfortable with what they're used to. You're never really going to have a physician jump at the chance to get something implemented that they're not really familiar with. So what we want to do is make sure we have a communication plan out there for them to be able to understand why we're doing this and how this is going to impact them. So with that communication plan, it starts today with the presentation of this analysis. The second thing we want to do is release a memo to the Physicians Affairs Department, as well as the Medical Executive Committee, explaining why we're looking at doing this. The third thing we need to do is actually purchase the pilot period reagents. And then the fourth thing we need to do is a validation study. Following that validation study and the successfulness of the implementation of this new technology, we'll want to take a pilot program with a few physicians to actually make sure that what we're doing is doable. And then pending the outcome of that pilot program, we're going to want to go live by Q1 of fiscal year 2021. So I hope you enjoyed this presentation. I know I kept it very simple, but I wanted to make sure that it was understandable to anybody that wanted to look at this. And I welcome any feedback or commentary you may have. If there is any, feel free to reach out to me. My cell phone number is 551-486-6331. And my email address is mp as in Peter, Steeg, STEEG, @gmail.com. So thank you again for your time. I appreciate all the help that you've been during this, and I hope you enjoyed this presentation.